Welcome to GNP Sir classes. In today's lecture, Professor Govind Narayan Purohit explains the drugs acting on the respiratory system. First, let us understand the functions of the respiratory system. The respiratory system delivers oxygen to the cardiovascular system and removes carbon dioxide. Maintains adequate oxygen supply. Maintains acid-base balance. Provides the sense of smell and plays a role in temperature regulation. Here are the contents of today's lecture: the classification of respiratory drugs, their mechanism of action, the clinical implications, and the adverse effects and safety. Now let us classify the respiratory drugs. The drugs acting on the respiratory system can be classified as expectorants and mucolytics, antitussives, bronchodilators, respiratory stimulants, and the therapeutic gases. Expectorants. Definition: increase the fluidity and volume of respiratory secretions, relieving pain and reducing coughing. Classification: inhalant expectorants. Examples: benzoin, eucalyptus oil, volatile oils, wood tars, turpentine oils. Administration: inhalation, steam or aerosol. Use: chronic respiratory disease. Guaifenesin. Clinical conditions: cough, bronchitis, pneumonia, other respiratory infections with thick mucus. Dosage: horses, 10-20 mg per kilogram body weight, orally, every 4-6 hours. Dogs, 2-5 mg per kilogram body weight, orally, 2 to 3 times daily. Route of administration: oral, syrup, tablets. The ingested expectorants. Examples: ipecacuanha, squill, balsam of tolu, sodium iodide, potassium iodide, ammonium chloride, guaiacol, glycerol guaiacolate, guaifenesin. Administration: oral. Mechanism: some are nauseants, subemetic doses, stimulating bronchial secretions. Iodides increase secretory activity. The mucolytic expectorants. Definition: liquefy thick pulmonary secretions. Examples: acetylcysteine, bromhexin, demrexin. Administration: inhalation, acetylcysteine, oral or parenteral, bromhexin, demrexin. Mechanism: acetylcysteine breaks disulfide bonds in mucus. Bromhexin increases immunoglobulin and oxytetracycline in secretions, improves lysosomal function. Demrexin reduces coughing and mucus production. Dosage: bromhexin, 1 mg per kilogram body weight twice daily, small animals, 0.25 mg per kilogram body weight, horses. Demrexin, 0.5 mg per kilogram twice daily, horses. N-acetylcysteine, NAC, clinical conditions: thick mucus secretions, often used as a mucolytic adjunct therapy. Dosage: dogs, 10-25 mg per kilogram body weight, orally, 2 to 3 times daily. Route of administration: oral, capsules, solution. Antitussives, cough sedatives. Definition: depress the cough center and reduce coughing. Use: painful, non-productive, distressing, or exhausting cough. Should not be used with copious respiratory secretions unless coughing is excessive and causing exhaustion. Classification: direct-acting antitussives. Mechanism: local action via demulcents, honey, syrup, coating inflamed mucosa. Benzonatate depresses cough reflex sensors. Centrally acting antitussives. Mechanism: act on the cough center in the medulla oblongata. Examples: codeine phosphate, morphine, dimorphine, butorphanol, hydrocodone, folcodine, noscapine, dextromethorphan, and dextrophon. Administration: oral, parenteral. Dosage: codeine, 1-2 mg per kilogram orally. Butorphanol. Clinical conditions: dry, non-productive cough, often used for kennel cough in dogs. Dosage: dogs, 0.05-0.1 mg per kilogram body weight, orally, 2 to 4 times daily. Route of administration: oral, tablets, injectable. Dextromethorphan. Clinical conditions: dry, hacking cough. Use with caution in animals. Some formulations are toxic to cats. Dosage for dogs: consult veterinarian. Route of administration: oral, syrup, tablets. Now we talk about the bronchodilators. Bronchodilators relax airway smooth muscle, relieving dyspnea and reducing coughing stimulus. Use: respiratory disease with coughing and dyspnea. Classification: Methylxanthines, examples, caffeine, theobromine, aminophylline, theophylline. Mechanism: inhibit phosphodiesterase. Administration: IV, IM, SC, aminophylline. Sympathomimetics, examples, adrenaline, isoprenaline, ephedrine, salbutamol, clenbuterol, terbutaline. Mechanism: stimulate beta-2 adrenoceptors. Anticholinergics, spasmolytics, examples, atropine, eucotropium, ipratropium. Mechanism: block muscarinic cholineceptors. Corticosteroids, examples, prednisone, prednisolone. Mechanism: suppress inflammation and reduce mucosal edema. Administration: oral, parenteral, aerosol. H1 antihistaminics. Mechanism: parasympatholytic, local anesthetic, CNS sedative actions. Sodium chromoglycate. Mechanism: stabilizes mast cells, prevents mediator release. The beta agonists work by stimulating beta-adrenergic receptors, leading to relaxation of bronchial muscles and improved airflow in asthma and COPD patients. The anticholinergics block the action of acetylcholine, reducing bronchospasm and mucus secretion, vital in the management of chronic obstructive pulmonary disease. The methylxanthines, such as theophylline, enhance the contractility of the diaphragm and have bronchodilator effects, though their use is limited due to a narrow therapeutic index. Corticosteroids reduce inflammation by inhibiting the migration of inflammatory cells, making them crucial for long-term control of asthma and other respiratory conditions. The leukotriene modifiers interfere with the leukotriene pathway, decreasing bronchoconstriction and inflammation, often used for prophylactic treatment in asthma patients. The mast cell stabilizers prevent the release of histamine from mast cells, diminishing allergic reactions, and are employed primarily for asthma prophylaxis and allergic rhinitis. We discuss in some more detail the mechanism of action of bronchodilators. The beta-agonists relax smooth muscles in the airways by stimulating beta-adrenergic receptors, leading to bronchodilation and improved airflow. The anticholinergics block the action of acetylcholine on muscarinic receptors in airway smooth muscles, reducing bronchoconstriction and mucus secretion. Corticosteroids reduce inflammation by inhibiting multiple inflammatory cytokines, decreasing airway hyperresponsiveness, and reducing mucus production. Other anti-inflammatory agents include monoclonal antibodies, which target specific inflammatory pathways, providing targeted therapy for airway inflammation. Now we discuss the analeptics or the respiratory stimulants. The analeptics stimulate the depressed respiratory center. Examples: pentylentetrazzole, Doxapram, nicotinamide, bumbride, carbon dioxide, ammonia gas. Use: hypnotic, sedative drug poisoning, acute respiratory insufficiency, apnea, respiratory failure, reverse respiratory depression from anesthesia. Limitations: narrow margin of safety, not for long-term support. Adverse effects, vary depending on the drug, can include hypertension, arrhythmias, coughing, vomiting, tremors, and convulsions. Dosage: Doxapram dose for calves, recommended dose for neonatal calves, intravenous, IV, or sublingual (SL) administration. Dose: 0.51 mg per kilogram body weight. The therapeutic gases include oxygen and carbon dioxide. Oxygen use: hypoxia, carbon monoxide poisoning, gas gangrene. Administration: mask, endotracheal tube. 4 to 6 liters per minute. Carbon dioxide use: respiratory stimulation. Should be used with caution. Clinical applications. Asthma treatment. Short-term relief. Short-term relief for asthma involves using bronchodilators, such as albuterol, to quickly relax airway muscles and improve breathing within minutes. Long-term control of asthma includes using inhaled corticosteroids, long-acting bronchodilators, and leukotriene modifiers to reduce inflammation and prevent symptoms. Chronic obstructive respiratory disease, COPD. To prevent exacerbations in COPD, patients use inhaled corticosteroids and long-acting bronchodilators. Maintenance therapy for COPD involves the regular use of long-acting bronchodilators and inhaled steroids to maintain stable lung function and prevent flare-ups. Antihistamines are commonly used to treat allergic rhinitis by blocking histamine receptors, thus reducing symptoms like sneezing, itching, and runny nose. Nasal corticosteroids help to reduce inflammation and congestion in allergic rhinitis, providing relief from symptoms when used consistently over time. Decongestants address nasal congestion by shrinking swollen blood vessels in the nasal passages, though they are typically used for short-term relief. Adverse effects and safety. Here are the common side effects. Bronchodilators often cause tremors, nervousness, and palpitations as common side effects due to their stimulant properties on the sympathetic nervous system. Anti-inflammatory agents can commonly lead to side effects such as gastrointestinal upset, increased risk of infections, and potential liver toxicity with prolonged use. Corticosteroids may lead to severe effects like adrenal suppression, osteoporosis, and peptic ulcers, particularly with long-term systemic use. Overuse of bronchodilators can result in significant cardiac arrhythmias, possibly leading to severe cardiovascular events and decreased overall medication effectiveness. Drug interactions. Common drug interactions include interactions with beta blockers, which can reduce the efficacy of bronchodilators, and with other CNS stimulants. Contraindications and precautions often include patients with cardiovascular conditions, untreated infections, and specific allergies that could exacerbate adverse reactions. Thanks for watching. Share, like, and subscribe GNP Sir Classes Official. See you again. Bye.